Dave, I take it CTO is... Okay, everybody, I'd like to thank you for attending our Innovators Den. I just wanted to give you a little background of how this came to fruition. We looked at our membership, both our members and our commercial members, and we looked at all the innovative, dynamic programs and opportunities and products that are out there on the commercial member side of our organization. And we thought, what a great way to bring our commercial members into a situation where they could basically demonstrate the innovative technologies and products that they have, because they may not always get a chance to be in front of the owners and operators. So we looked at tonight as a way to feature some of the top programs out there that we thought would make your lives a lot easier in the long-term care environment that we're in today. So what we're going to do is we're going to start. The 4 people that are being featured and the 4 companies tonight that are being featured actually have already won the status of the Dragon's Den or the Innovator's Den. We went through a process. There was a lot of submissions, and they were all very good, but we feel that these 4 really shone and really had something very innovative. And I know you've all had the chance to experience their products and their programs today. So what we're going to do, each company has 10 minutes to basically do their presentation, and then there'll be a 5-minute period, and then we're going to have the other company come right back up. So what I'm going to do is just tell you a little bit about the 4 people that are going to be presenting, and then what I'd like them to do is just come up, give a quick intro of who you are and or what your company is and what your product is, and then you can launch into your presentation. So the 4 finalists for our Innovators or Dragon's Den is Dave Wessinger, CTO, Point Click Care with eInteract, which we heard a lot about today, which is pretty phenomenal. And then we have Eva Borland, Territory Sales Manager, Long-Term Care Corporate Accounts for Smith & Nephew with the Pico. And then we have Michelle Mangello, the Clinical Director for First Quality and Residence Dignity in Continence Care. And then we have Christine Thurer. I hope I didn't slaughter that. I apologize if I did. Okay. And she is presenting on building culture of mutual support. So first let me get a big round of applause for these 4 finalists. And I'm going to turn the mic over to Dave.
Hello, everyone. I wish I had a glass of alcohol in my hand, but it won't be very long before I do, I can assure you. I'm Dave Wessinger. I'm the CTO of Point Click Care. Hopefully you've heard of us. I actually, just a bit of background, I started off, believe it or not, working for somebody who you might know. Bill Delane, ring any bells? Maybe. I see some familiar faces out here. I used to work on the provider side, and so worked for the responsive group of homes back a number of years ago. I won't say how many. But it's interesting, the folks that I think I remember back then still seem to all be here, so I don't think any of us have aged, so I think that's great. So we have, I think, a really interesting innovation that happy to be here to talk to you about, and I think you had an opportunity to hear from Dr. Oslander directly today. So I'm hoping he didn't steal any of my thunder. But is there oh, got it. Okay, so I'll just give you a little bit of background on how we got to know Dr. Oslander, because I think it's important in terms of how we came together and where we want to go together with the Interact program, if you will. It started back about a year, maybe 14 months ago, and Brother Mike and I had heard from a lot of folks and heard the noise around Interact, and we're a little thick, so we wanted to find a little more about it. So what did we decide to do? Well, we thought worst case would be if we go down to FAU, visit with Dr. Oslander and his team, we'd at least get around to golfing. Lo and behold, what we found, and I think what really drove us together to this great innovation, was that we had a platform that services pretty close to 50% of the North American market, And Dr. Oslinder and his paper-based tools in Interact were getting some broad-based adoption, Interact being interventions to reduce acute care transfers. And so that was getting a lot of play, and the ability to work together with the platform and reach that we have to take the clinical protocols or the quality improvement program, I think is how he'd like me to refer to it as, and I've been coached. The ability to take that and layer that in and instantly make that available to so many clinicians and care providers was what we thought was a great opportunity, what effectively this innovation is all about. So what's eInteract? Interact is commonly known as, or at least used as more of a paper-based tool set, and as such has limitations. And so if you can think of bringing that to life, we equate it from going from snail mail to email. That's the difference between a paper-based model and what we see as eInteract. And so we have what is an exclusive arrangement to work with FAU, Dr. Oslinder and his team, to promote and grow and not change, but collaborate with the market to drive eInteract to what we think it can be in the electronic world. And so we're the only group that he's chosen to work with, so we feel very special. We also are driving some funding to help improve that program as well as we work together. We're the first only ones to move towards embedding it in our EHR framework. So there's lots of EHR folks out there, but we are the ones that are working collaboratively with them to drive and set the standard for what is eInteract versus what is a paper-based version of it. It's not an adaptation. I think that's important to say. It's easy to take a paper-based assessment and put it into at least our product. I think that's true with some. But the value you get from really leveraging and creating triggers and workflow off of discrete information that you can learn or driving clinical decision support is tremendous. So it's not just replicating what's on paper. So for those of you, and maybe I'll get a show of hands, how many of you are familiar now with the Interact program? So a fair number. I would think within the next year it's going to be just about everyone and most of the people that you work with. So the innovation, it's really taking this crossroads of Interact and HIT and health information technology, and I'll explain it a little bit as I get to the roadmap and the things that we're going to deliver, is really leveraging the information that we have to improve the quality of care. I mean, that's what we're really after. And again, I've talked about some of that. The other thing that we like is we're not here to create something and say, well, this is, we think this is great, so you should use it. It's evidence-based, it's got good history, it's got good research, and it's got the right people behind it. So it's not Mike and Dave and Point Click Care making something up in a corner. We're really leveraging industry best practice, and I think that's what I'm hearing from most folks, is that's where we want to be, that's where we want to go, and that's how we want to measure ourselves. We continue to fund further research, and what we have done as well to ensure we have the participation beyond just ourselves and FAU and those folks is we've opened up an advisory council across North America, and there are some participants, I think, in the room on that council. I think it's, Terry's about 15, 20 folks collaboratively working with us to evolve eInteract to an electronic standard, so I think that's outstanding. And really being the first to do it. So that's how we think it qualifies for the innovation den. Just to quickly go through how we see it working, and again, on paper it's very easy, but very limited. And so when we look at on the left-hand side, your left, you'll see in my mind would be a PSW. So they would be interacting with HIT. They would denote basically an alert. That alert would flow to the clinician. The clinician would leverage the information, be that a point-of-care alert or something indicating there's a change in condition, or leveraging the stop and watch, and think about that being embedded in they see something, they click a button, now there's an alert. That alert, and again, when you think about an alert on paper, it doesn't travel. But you think about a text or think about Twitter, that gets around, as we all know, very quickly. But the ability to take an electronic message and instantly get it to the folks that should respond to it, and then have the ability to ensure that it's being responded to. Two very, very important steps. And I think when we talk about getting to that next step where how do we engage in a consistent way with the physician to give them the right information in the right form so that there's not a disruption there and we make the right decisions, you look at the S-bar today and you look at a care pass that might get you to how you would fill out that S-bar. It's a very standard structured form. Well, when we're electronic, we can make sure it's dynamic to what information needs to be on that form and sharing the appropriate information, not everything that would be on a static form. So we get a lot of opportunity there to share what's important. And as a result, getting that information and communicating and looking at the same information in the same way, we get an ability to control that outcome, and ideally, the best outcome in most cases that they stay in the home. If there's a need to transfer a hospital, it's preventing the potentially avoidable hospital transfers, because generally, as we all know, that's not good for anyone unless it's required. And so you really get an opportunity to improve the outcome, take a program that's evidence-based, that everyone can participate in a consistent way, manage it, create transparency, and ultimately improve your outcome and your resident quality, your quality of care. So that's really, in a nutshell, what it's about. I'll quickly go through a roadmap. I'm probably running out of time. I think if you kind of go from left to right, it's starting to get to, I had a hospital transfer portal, which is an ability for you to measure and look at what's driving you to do readmissions, time of day, physician, diagnoses, and furthermore, getting into doing some quality improvement around that activity, and really get some trending, getting into when you do send them to hospital or transfer them out, what kind of information is appropriate. And we deal with health exchanges a lot. And it's not clear to them what information they want. They just want information. And so with the transfer form, and certainly version 3, it's very clear the kind of information that's important if you're going to have continuity of care on transfer or discharge. And so moving on, the embedded communication and decision support tool, so getting those care cards or those care paths and allowing folks to really leverage, okay, here's what I saw, here's the stopwatch, here are the observations, here's the information, what do I do? And really drives them down a path to create that consistency that you want to have with an evidence-based program across your organization. And then getting into the quality improvement tools and reporting, which is another key component, the messaging between care providers, and then ultimately getting a certified product. So although we're leading here, we feel that eInteract shouldn't be held back from anyone or everyone. If you're on other platforms, we'll work collaboratively to define the requirements, the standards, the criteria, and then allow eInteract to certify other software companies to do it, so that it continues to be available to all that want to improve care leveraging the eInteract standard. What you can do to learn more, or kind of where we are today, there's an eInteract.org site you can learn a little bit more about. There's webinars. Start tracking them, start using tools to understand what your readmissions look like. I know that's clearly a priority today. And I would say across every jurisdiction, whether it's the UK, Canada, the US, you name it, everybody's looking at returns to hospital. So this is clearly a widespread issue. And I think, Dr. Olson, you said you were heading to Singapore. He's probably up working in his hotel room, but off to Singapore to talk about the same thing. So this is not contained. It's a universal issue. And obviously improving with that quality improvement tool. So I think I've probably used about all my time. Any questions? Yes?
So will the QI tools that are going to be embedded in there, will they follow when the new regulations in the United States come out on quality assurance improvement, will kind of support that platform?
It will be an approved quality improvement tool from that perspective. But the quality improvement is really about having the right, if you look at the quality improvement tools that are in the Interact program today, it's about taking those and putting them to electronic format.
Will it interface so like the QMs that the MDS is already?
So QI-QMs, I think, are a little bit different. This is really about the quality improvement around the transfers versus specifically QI-QMs. Yes? Actually, we were just talking about how we would go do that. I think they're still discussing the requirement phase. So, sorry, thanks, Reed. The question was what's the time around doing the care pass? And I think that the initial focus, as you saw, was getting the measurements around the transfer, so understanding the problem, and then really getting to that piece. And so we have design sessions set up, meeting with Dr. Olson and his team, and that's really the focus of the group, of the North American Advisory Group, to sit down and talk through. We'll present what we think it should look like and get some feedback, and if that goes well, then that will be where our development resources go next to build out those care paths. So I would expect it's a 2013 initiative, but depending on how big the scope is, we'd certainly like to contain it so we can get it out in the year. That would be ideal. Yes? Question is, would it be to all our Canadian customers? Yeah, it would be offered to all of our customers across the board. Yeah. Excellent. Oh. I think that, yeah, that's essential. And we've been talking with OLIS about how we can get that data. So we've had lots of conversations. We've started to design out how that information can be discreetly received. We've got all the specs. We've been working with that team and on a regular basis. I'm not sure I have the exact time frame to commit to up here, but I think that if we're talking about engaging with a physician, it's critical that we have lab result data, number one. Okay. Relevant. Actually, what's in OLIS does codify, I believe it needs to be standard in a standard format before they'll receive it from the lab. So when we get it, it is standard across the board. So that's the value OLIS does provide. Okay. Thanks very much. I'll be around and probably at the bar.
Good evening, everyone. My name is Eva Borland. I'm a registered nurse, and I'm with Smith & Nephew. I'm the long-term care manager for Ontario. And what I wanted to do is to introduce you to an exciting and an entirely new way to deliver negative pressure wound therapy. Your challenge is to offer effective treatment options that are within budget and easy for clinicians to incorporate into daily practice. Pico has the answer. Pico offers all the effectiveness of traditional negative pressure wound therapy in an easy-to-use device that significantly reduces therapy costs. Sorry, Candace. Which one is it? Not that one. Brian, help. Oh, there you go. Is that it? This one. I think this one. Okay. No. Okay, there we go. I got it. Thank you so much, Candace. So how does negative pressure work? The mechanism of action are that there's a pressure gradient, the fluid shifts, and there's a reduction in edema. And as we know, and if you don't know, then of course edema is a barrier to wound healing. So if we reduce edema, we get better healing. Perfusion is increased with the delivery of oxygen and nutrients. The bioburden is managed because we're able to pull off all of that exudate. And of course, the mechanical forces which contract and have an effect on the cells. And of course, in the end, granulation tissue is formed. So in terms of innovation, I love the fact that we always are coming up with new innovations with Smith & Nephew. And on a daily basis, we service over 2,200 accounts with over 4,000 patients with being treated by our devices. So we have something for all your resident needs. If you need to pull off a tremendous amount of drainage, then we have, of course, our Renesis, and that's technology that we know. But there's a place where we need something that's easy to use, that pulls off that drainage, that gets and accelerates our wounds to heal faster. So what is Pico? Well, Pico is a new, simplified negative pressure device that differs significantly from previous negative pressure in two aspects. First off, the device is constructed to operate without a canister. Okay? And the second is the device is lightweight for single patient use and recyclable after 7 days. It delivers 80 millimeters of pressure, is up to 7-day life. It's battery powered and one button for simple operation. It's small enough to fit in the resident's pocket and for total portability. And of course, this improves quality of life and therefore increases the likelihood of patient compliance. Not only that, but what I'm finding when I go into the facilities, the nurses aren't afraid of it. They embrace it, and therefore outcomes are quite tremendous. So it's a dressing. All the exudate goes into the dressing. And the dressing is a high MVTR upper film, which means there's a tremendous amount of exudate that's going out into the air. It's got a super absorbent layer, an airlock layer, and a silicone adhesive layer that is very gentle on the skin. In fact, whenever we do these dressings, when we take the dressing off, there is no maceration on the resin at all. The pressure is evenly transmitted by the airlock layer, which doesn't collapse under negative pressure, and the perforated silicone adhesive layer transmits negative pressure to the wound bed and removes the fluid. So in terms of the exudate management, it just simplifies negative pressure. It replaces the exudate canister. The water vapor passes easily through layers. And when you use the Pico, you expect to use only a single 30 ml canister, okay, in a 7-day period. So it's not for those highly exudating wounds. Those still need the canister. This is for when you want to accelerate wound healing and you still have quite a bit of drainage, mild to moderate. So, clinical indications for use, low to moderate, chronic, incision sites, acute, traumatic, subacute. We're having excellent results with pionidal cysts, pionidals. Like, they're a terrible thing, and we are having really great results with that. Partial thickness burns, ulcers, and flaps and grafts. Where I don't want you to use Pico is, of course, with anything with extensive undermining, with a tremendous amount of exudate, any sternal wound, exposed organs, and, of course, a large exudate. So what are the clinical advantages? Well, you know what we want to do with any wound is to increase wound contraction. We want to splint the wound. We want to make sure that it's in a moist wound environment. We want to eliminate exudate and small debris. We want to increase circulation and perfusion, which is what this product does. And it reduces edema, which accelerates wound healing. And, of course, we can use fillers with it if need be. Also, people ask about the environment. It's really important to all of us. I think we all believe that we don't want to do anything obviously worse to that. And so the pump itself can be recycled at an electronic recycling depot. The batteries can be multi-purposed for any of your homes. And of course, reducing the number of dressings in landfill, where maybe there was 3 to 4 with those big canisters and everything, we're now 1 to 2 and a quarter of what was being used before. The package can be recycled and lower overall carbon footprint. So, as we talked about, it is battery powered. It can be used with wound fillers. We do recommend that you use it with a silver dressing. Acticoat Flex is working very well with this particular product. And we do have saline moistened gauze that we also have. And we do have a foam that can go underneath the Pico. 3 lights communicate the status. Green is okay. Amber is leak, and the battery may flash if it's been on too long. There are 8 dressing sizes, 1 for everything and every one. And of course, this is an example of the application. Christina, who's an esteemed colleague of mine, has a Pico on, and it would take probably about 2 to 3 minutes to apply this dressing. Again, it's peel and stick and turn on the battery. Okay? Thank you so much for your time. I thank the committee for picking us as one of the innovative products. And if there are any questions, I'm happy to answer them. Yes, Candace.
Is there another comparable product on the market right now?
Thank you, Candace. No, there is no comparable product at this time. Nope, we're the only ones. Yes.
Would this be something that would pass as a product to use on exceptional wounds for high-intensity?
Thank you, Candace. This is, that's a very good point. Thank you so much. Is this a product that can be used on exceptional wounds? Because that's what the ministry is looking for. When you you fill out that form, it has to be an exceptional wound. I think we all know that. And yes, it is. Absolutely, this is for exceptional wounds, and it is covered by high-intensity needs. Thank you. Any other questions? Yes.
I recently actually had a recommendation
Okay. As far as I know, there is nothing like this right now. They do have different other products, but they're all about the canister. But I could be wrong. I haven't seen anything from them at all, but that could be. Yes, Candace.
So would you kick off a wound? Would you use this as a kickoff before you go to the canister to see if this would work? Like, what's the? If you're looking at a stage 3, stage 4, it's kind of up in the air. Would you try this first because it's more economically feasible?
Right. So when you're looking at, when you're looking at this type of product, that is exactly the case. You will try this. Remember what the presentation said. If your wound is less, around 300, where you would do a full canister, this is and can be a really good option. It is probably about a quarter of the cost. Now, Christina, we put, and as an example, on the plastic board, what I did was I started putting in Diet Coke into this dressing. And what happened is that it pulled off in about 5 minutes. I put about 75 mils. It pulled everything off. And the evaporation, the difference between the evaporation and the pulling is it went almost clear. So that's how it works, and it is a viable option. And what I really found was that the nurses in the home, because it was so easy to use, embraced it, and therefore you really did get good results. Yes. Any other questions? Well, I thank you so much. Thank you.
Good evening. My name is Michelle Mangello, and I'm the Clinical Director with First Quality Products. I'm also a registered nurse. And just to give you a little information about First Quality Products, we are the leading manufacturer of adult incontinence products in North America. And today I'm going to talk to you about two different things. I'm going to talk about a product innovation that we have, and I'm also going to discuss some program innovation that we have. First Quality has really been one of the first companies that has come out with incontinence innovation as far as a thin core technology. And we are the first company that went to a breathable back sheet on our products as opposed to those old plastic products that we used to use. One of the products we have, and if many of you probably saw them out at the table today, is the boxers that we've developed. We're the first company to have a boxer brief for men. In the long-term care facilities, we really were hearing a lot of feedback, especially from men that were very social and active in the facility and not wanting to use a diaper product or a two-piece product, but really wanting something that fit them like a boxer like they were used to wearing. We have some of the results up here of an independent study that we did, and the men that were in the focus study really reported that they felt more normal. They said the boxer felt like regular underwear. They felt that it was discreet under their clothes. They reported that they got out of the house more and also out of their units if they were in an assisted living or a long-term care center, because they felt like they were wearing a regular product. So we're very proud of the product. We have a lot of samples out at the table if anyone wants them, but it is something that we really have had a lot of good feedback from, not only in the home care setting, but also from the independent assisted living and mainly long-term care, especially for those residents that are up and about in the facility and maybe going out on pass, et cetera. The other program that we have is a clinical program. First Quality has a number of clinical programs that we to support our customers. One of them being our Total Care program that looks at restorative nursing and toileting programs, as well as MDS support for the facilities as it relates to Section H of that program. And the eNurse program, and I know it'll get there in a second, our eNurse program is a new program that we have that supports your facilities from a webinar and from a video conferencing standpoint. It's not a replacement for our nurses that go in, but it really is an adjunct to our clinical team. And this individual is available, believe it or not, on a 24/7 basis. And we're really starting to target the night shift for education. I know when I was a director of care, we kind of sometimes forget about that night shift when it comes to providing them the education that they need, other than just maybe a videotape that they might put in at night. So we have a dedicated nurse now that's available to provide education on a variety of topics. They are mainly incontinence related. They can be on UTI prevention. They can be on our products. They may be on helping reduce that acute transfer to the hospital, as we discussed the previous speaker. And it really is to give kind of a one-on-one to not only the day shift staff, but the night shift staff as well. It's been very, very successful, not just from doing presentations, but also being a support and having a live person to talk to about a number of things. She's also been very instrumental in working with facilities and setting up restorative toileting programs and having a conference room full of PSWs and nurses in a room where she's meeting them at a regular basis, maybe a weekly time frame where they're setting up brief educational series for a half hour or so and going over the foundation of restorative nursing and how the facility can get their residents up and functioning in a toileting program. Are there any questions? Candace? Thank you, Candace.
Have to wear an incontinence product. Have you had any experience or any feedback around those aggressive residents that it's the dignity issue that's causing?
Yeah, thanks for bringing that up. Specifically on those units where they're a dedicated unit, and we all know that whole toileting process can be very, very overwhelming for males and females. And when we use some kind of either pull-up brief or this kind of boxer brief, it is much easier, and it's a more normal procedure for them. They aren't used to having someone or two people come in and put a brief on or do something like that. But when you have something that is a product that they're used to using their entire life, it's made a big difference. We've actually seen some of those units go completely away from using any kind of brief product, and they're using either a pull-up or a boxer type product or a pad. They're just not even really allowing briefs on the unit because it has decreased that behavior. They're yeah, and if they're not using the pull-up appropriately. And, I think the pull-up or the protective underwear, as we like to, call them, when you look at them as opposed to a product like this, they still kind of look like a brief because of the way that the core and everything is built in there. So we do see a little bit more adherence with it. I also think that this is really such a great toileting product because it looks so much like underwear. We've had staff report to us that it's easier for them to take them toileting because they feel like that's what they're supposed to do, because they're wearing regular underwear. Any other questions? Well, you know, tomorrow's Valentine's Day, so if you haven't picked up your gift, and for you guys that want to wear something nice tomorrow night, so I just want you to know we have a ton of these out there, so thank you.
Good evening. I'm Clayton McKay, CEO of the Java Music Club. Christine, my partner Christine Toyer, is the founder and creator of the program and co-founder. And she asked me to do this speech tonight. Usually she does these things, but she said, "How far wrong can you go in 10 minutes?" Well, we'll see. Okay. I'm here with the Java Music Club. Loneliness and depression is a huge problem in long-term care today. We're all familiar, where's my thing? With the CIHI statistic that 44% of residents in long-term care have been diagnosed or suffer from depression. It's an epidemic and a moral and social crisis that presents many challenges and affects our day-to-day operations. Depression is linked to cognitive impairment and dementia. Dementia is also linked, according to the CIHI in this fancy chart, to withdrawal from activities of interest, conflicts with staff, and severe aggressive behavior. Resident aggression has been in the news lately, and there's also links there, I'm sure. Setting aside dealing with the effects of depression puts tremendous burden on staff and resources. Setting aside the moral considerations, what impact does depression have on the costs of our day-to-day operations? The New England Journal of Medicine published a recent study, like last week, that concluded older adults with mental health disorders and depression have poor health outcomes, higher rates of hospitalization, and more emergency room visits. The per-person costs are 47% to 200% higher than a person with just physical illness. It's 47% to 200% higher, and the cost keeps rising as the mental health needs of the resident population increases. Dr. Sinha states, if left unaddressed, our demographic challenge could bankrupt the province. So what can we do to tackle loneliness and depression? We see from the research here today, including the poster sessions, Java Music Club was happy to be able to sponsor today, that good work is being done. Much of it is focused on person-centered care or psychosocial support to address resident mental and emotional health needs. We know emotional and mental health affects our physical well-being, and this is where mutual support groups shine. Although mutual support groups have been around in the community for many years, the Heart Stroke Foundation, Cancer Foundation, AA, they are not found in care homes. Properly implemented and facilitated, however, mutual support groups provide a structure and environment that foster peer support among residents. They can be facilitated by paraprofessionals such as activity staff, but laypersons like PSWs, committed volunteers, family, or even high-functioning residents can also facilitate a group as long as there's a clear structure and format to follow and a little bit of training. The magic of peer support is not in what we can do for them, but what they can do for one another. Thomas Kitwood's theory of personhood, Reisman's helper therapy principles provide the theoretical foundation for the use of mutual support groups. Theories of innate human traits, such as reciprocal altruism, also help explain why these programs resonate so well with seniors. It gives them a chance to be of help to one another, and that type of action can yield huge emotional benefits. Some philosophers believe altruism is a spiritual glue that holds society together, and when we don't practice it, we wither and die. The Institute of Medicine in the U.S. recognizes peer support as an integral component of a mental health program. The OLTCA report, Why Not Now, proposes engaging residents in self-care as part of the solution. We'll get some first-hand reports in a minute, but let's take a look at how the Java Music Club program is set up to provide a format and structure that works. The program was created by Christine Toyer. She was a music therapist about 10 years ago and founded the first Java Music Club as a trial social group. She created guidelines. She recorded 142 songs with Linda Kidder, the bass player for Katie Lang, and in lower singable keys at a slower tempo so residents could sing along. Incorporated a Native American talking stick to the group, so whoever has a stick gets to share. The quieter ones speak up, and the noisier ones have to listen. Very effective tool, even for your staff meeting. Large format photography was incorporated to stimulate discussion with people that may not share on a topic, but are stimulated by a photograph. Discussion themes were tested and retested, so they had selection of topics that encouraged sharing from the heart. This is not for entertainment or for reminiscing. This is designed so that residents really open up, unburden, and get to know each other. The Java Music Club program was tremendously successful in that care home. Went from one group to 6 groups running. Christine decided to package it up and see if it could be transferred to other facilities and other facilitators. A training DVD was created. And with simple to follow guidelines and pre-recorded music, almost anyone with an interest in people would be able to run the group. She received funding from the Michael Smith Foundation and SHRC to do her study through the Simon Fraser Department of Gerontology. And the results were published in the... I should have been clicking my clicker. Whoops, one sec. And results have been published in the Journal of Applied Gerontology. So here's a video of some of the comments from staff and residents in one of the care facilities that we put in the program.
Java Music Club, the experience I had when I first attended that program was magical. How it's set up, especially with that American Native talking stick. It creates that magic where you have the power to speak, and it brings a lot of the spirit of sharing out of people. So it's really interesting.
Being able to sit and talk with them and hear their stories, their emotions, their happy times, their sad times. And they cry sometimes, and sometimes we laugh. So you get a wave of emotions that happen.
It's interesting what it's like for Shirley to be in this group is that she is very open, and I can see the love, and she enjoys the singing very much, and she enjoys sharing. I think that above all, she likes to enjoy sharing because not too many people listen. When a person with Alzheimer's talks, people don't listen. They think they don't have anything to say.
I'm part of the group, and that part means so much.
Great. So mutual support groups can be a catalyst for culture change within a care home. It sets a tone of positive mutual support that is carried out into the halls, the dining room, and into interactions with staff. Another part of the Java Music Club program is the mentorship component that gives the staff and residents tools to seek out the more lonely and isolated resident and invite them to the group. The program can also be used to enhance your resident council. After it's been operating, residents are used to sharing and getting beefs off their chest and talking to each other, and that's very helpful for the resident council to get more input. The program has been implemented in Schlegel Villages. Has finished. They've implemented in 5 of their homes or 6 of their homes initially, and now have put it in the remainder. Some of the feedback from them has been great. Everyone's loving the program. This just goes on. I won't bore you with all of it. But we really have had no negative feedback. It's quite, residents love it. There's zero attrition rate except for the normal reasons, or usual reasons, but residents love it. And one of the problems is you have more and more residents coming to it. But it's easy to start new groups. This one I left in is from the Yukon. It was so over the top that I had to leave it in. And I'll just cycle through these. Responsive management has implemented it in all of their homes. We had a full-day training session with them, and this is some of the resident comments, or some of the, this is resident feedback. University of Alaska in Anchorage has started a full RCT trial on the program, and we hope to get results from them next year. Our newest motto is, let us help you, help them, help one another. So, I don't know what happened there. But anyway, it says thank you. Do you have any questions? Candice. I'm going to ask Christine. She promised to respond to the questions.
Thank you. So the question is, do we have any results on the impacts with behaviors? So we're still in early stages. Our first study was a process evaluation, so we included structured observations with that. And what we saw is that the different components of the Java Music Club, for instance, the first part of the Java Music Club is a getting centered practice, and where we play wind chimes. And that particular part of the program would really bring down the energy and the agitation that we found in what we call secured or special care neighborhoods where we implemented the Java Music Club. So it is still early stages. We have some trials coming up where we'll have more definitive data to give you. But just from our structured observations that we had in British Columbia, the results are tremendous. So how would members access the Java Music? So all you do is you go to our website, www.javamusicclub.com, right there on the screen. And all the information is there. The research is there. You can email us from there, and we can send you more information that way. Can you borrow the talking stick for your staff meeting? Yes. Board meeting, yeah. Yeah. That's great. Any other questions? Yes. How might, sorry, I can't hear.
How could the program be adapted for the various levels of Alzheimer's dementia that the clients that you're
Right, thank you. So we are, the program, the pilot that we did happened in a care home, but we have found since that the program is easily adapted in retirement homes, in assisted living, in adult day centers, and in particular in special and secured care. We call it special care in British Columbia, but you call it secured care here. And so what we found is that in retirement homes, the mentorship aspect, so the residents, the higher functioning residents in the program seeking out and involving the lonely, isolated residents has just been a tremendous part of really building community. And we're finding that we can do that same mentorship program also in secured care. So a resident, arm in arm with a staff member, going and seeking out the lonely and isolated residents, bringing them into the community. So what we do is we take the components of the Java Music Club and we adapt them slightly. So, the questions that we ask are concrete, not as abstract. When we do, for example, the getting centered practice that we do at the beginning where we use the wind chimes, we ask everyone to breathe in, get centered, helps the staff get centered and the residents. In secured care, we just take more time. We just take longer to do the whole procedure. Sometimes the staff take the Java Music Club and they do it throughout the entire day, if you can imagine. They just take the different components and slow everything right down. Yeah, thank you. Very good. Thank you very much.
I know. Okay, we're going to the board meeting now. No, just kidding. Board members. I just want to thank each and every one of our presenters. I think each of your presentations was phenomenal. It really excites me because, and I'm sure it excites all of our members in the room, because it just shows what's possible in long-term care. We have such innovative, remarkable products out there, and if we can do anything, we need to get that link for our commercial members to our members and foster that relationship more so that we can be a stronger presence in the healthcare sector. So a big round of applause for all 4 companies. You were phenomenal. Thank you very much.